for giving this opportunity of discussing tuberculosis, one of the, I think possibly one of the most common diseases that we encounter. But when coming into the possibly the medical teaching, we do not get to teach tuberculosis as theoretical because that's taken care by the respiratory department. So, but in the clinics we do see a lot of tuberculosis. By far, as Kishan said, every specialty, there's no specialty that can be spared of tuberculosis. So you have to know about tuberculosis, and India more often because we are by far one of the largest number of cases of tuberculosis, the normal tuberculosis, the drug-resistant tuberculosis. And the other important thing that we have is diabetes. Diabetes being one of the commonest risk factor for tuberculosis, and India is very soon going to be the diabetes capital of the world. So tuberculosis is nothing but it is going to increase, and we are going to have the disease. Though there's been a large amount of strategies that have been done to decrease the burden, newer drugs, the availability of drugs, and all those things are there. But this is the latest 2020, and this is what was published by the WHO and CDC. And if you see, India still here, it's around the number of cases that we see here, almost the dark blue. You can see that the African subcontinent has the maximum sort of color. The deeper the bluer, the more the deep the blue, the higher the incidence that is there. Again, this disease was not there in the West. US and Europe had almost eliminated this disease somewhere in early 80s. But with the onset or the coming of the HIV, the disease came back, and this disease came back, and that's why you have a lot of research that's being done on this disease and the drugs that are there. So today we'll be discussing tuberculosis is a vast topic because we have a large number of subgroups that could be discussed. But in the next 1 hour or so, let me try to at least highlight the important topics, both relevant clinically as well as for your exams purpose. So as we say, Mycobacteria genus would comprise of large number of bacteria which are other than tuberculosis also. India is the hub for Mycobacterium leprae also, so that's a very important disease that we do encounter. Atypical mycobacteria, especially you have your Mycobacterium avium cellulaire, which comes in HIV patients, we have discussed in the earlier session. And then you have the Mycobacterium tuberculosis complex, out of which you have the Mycobacterium tuberculosis, which is common. Bovis is common, though we do not subtype the diseases. We have the Africanum, which comes under that. These would manifest similarly. The treatment modalities would little differ possibly in each. Rifampicin is one drug which can work against all the Mycobacteria species. So way back in the early 1800s, that's where Robert Koch was the one who discovered tuberculosis and the pathogenesis of tuberculosis. And tuberculosis is associated with the entire development of the Koch's postulate, where an organism is associated with a disease. And tuberculosis is a chronic inflammatory disease, and it produces the classical granulomatous infection that is there. And the immunity that's predominantly involved is the cell-mediated immunity and the delayed hypersensitivity that is occurring. So common in India, this is the data in 2016, the number of cases that would be there that much. It is increased. It's increased thanks to the COVID last year when we had the lockdown for almost 4 months and odds. The new cases were not getting reported. The drug availability and the access to the drugs, especially in major parts of the area, was not available to a great extent, and that's why the disease has increased the burden. The numbers are anyway expected to at least increase by 20% what was there in 2019. By 2020 data will come in another 2-3 months. Definitely the number of cases is increased basically because people were not being able to access the healthcare. 10% global cases are associated with HIV. And the point that is very important is in the developed world, that is when we say about the US and the European countries, it is the reproductive females who are primarily getting affected by this disease. So 15 to 45 years, females are the ones in the developed countries, whereas in the developing countries, there is no exception. Starting from age 0 to age 70, possibly and above, tuberculosis could be seen in all. So it's an acid-fast organism that's there, and it's an obligate aerobe, and it is an intracellular pathogen which is located inside the mononuclear phagocytes. So you can see the acid-fast staining that's there, and it is having the mycolic acid that's there, so which makes it acid resistant. So it's acid fast and alcohol fast thing. Some common questions they ask you in your vivas is what are the acid fast organisms? So please remember the acid fast organisms is not only Mycobacterium tuberculosis, it could be Mycobacterium leprae. Nocardia is also acid fast, Isospora, Cryptospora, Microsporidia. So all these could be seen in a HIV patients. Rhodococcus is also acid fast and Legionella is acid fast. The other structures which are acid fast is the head of the human sperm, the embryophore of the tinea saginatum, hooklets of the Echinococcus granulosus, and keratin. So these are the acid fast structures or where the acid fast staining can be used for identification. A very common viva question asked, even in medicine we do ask these questions sometimes. So acid fast nature, again a very common question asked, though it should be asked ideally in pathology or microbiology, but even in medicine, even in MD medicine, they ask you about the staining method that is used. Okay, so the Ziel-Nielsen staining method and the modified Ziel-Nielsen method that we use, that is the Gabbard staining. Ziel-Nielsen has the heating process that is there, whereas the Gabbard does not have the heating process. So you should know what agent is used first and what is the color that is retained by that. So the first agent that you are going to use is carbol-fustian, followed by the heating. This is not there in Gabbards. Most of the, I think in the colleges we do is the Gabbard staining. Acid fast Ziel-Nielsen is not done everywhere. Then you decolorize using alcohol, 5% or 20% alcohol, and then you counter stain with methylene blue. The methylene blue is to counter stain the background, the cells that are there in the background that is going to be stained by this methylene blue. So it's a carbol-fustian followed by heat, followed by alcohol and methylene blue. Please remember, this is asked even in your MBBS, MBBS and MD medicine exams also. This process is asked and you have to know. And they consider it basic if you do not know this. Coming on to the sources of infection, as for all practical purposes, it is the human infection that is ones which spread the disease, the open cases of pulmonary tuberculosis. Now, are the extra-pulmonary tuberculosis communicable? They are the ones who can they spread? Now, the question is the GI tuberculosis, can it spread through the feces? If there is an open lymph node and secretions coming out, can it spread? It's very unlikely. It's the most important source that we have is pulmonary tuberculosis. Extra-pulmonary tuberculosis, generally, the spread is not through that. It is the pulmonary source itself. Other than the Mycobacterium tuberculosis, bovis can be contaminated. That is basically through the contaminated milk from the infected cattle. So generally produces the intestinal and lymph node tuberculosis sometimes is produced by Mycobacterium bovis. But otherwise, the source of infection is always an open case of tuberculosis. And again, remember, once we have diagnosed somebody has tuberculosis and we have started appropriate treatment, especially the rifampicin-based regimen, and the patient is drug susceptible, the patient becomes non-infective within 2 to 3 weeks. So within 2 to 3 weeks, the patient becomes non-infective. If the patient continues the therapy, definitely at the end of 2 weeks, the patient is not infected. So that's the importance of early diagnosis and management. So mode of transmission, it's inhalation is the primary mode. Ingestion, the oropharyngeal and the intestinal disease, and inoculation is rare, that could occur during laboratory process. Now the risk factors, if you see the risk factors, what are there? There are the risk factors which are producing the high risk of infection to tuberculosis and the ones which increase the progression to active tuberculosis. Now, being in endemic areas like in India, almost all of us have got exposed to tuberculosis and possibly we have some sort of a latent tuberculosis. So what increases the risk of progression to active tuberculosis is if the ages are in extreme. So supposedly the children below the age of 5 years, or if somebody has not completed the treatment, possibly as incomplete treatment, that's an important risk factor for progression to active tuberculosis. HIV/AIDS, very important. Malignancies, malnutrition, diabetes mellitus, immunosuppression of whatever sort. More important, it's important to remember now when we give monoclonal antibodies, etc., which are coming up for the treatment of arthritis or hepatitis, etc., that's where the tuberculous flare can up. IV drug abuse, alcoholism, chronic lung disease, and chronic kidney disease are the other conditions which increase the risk of progression to active disease. The ones who are at risk to get the tuberculosis is where you have people who are staying in a particular environment, long-term healthcare, long-term care facilities, maybe a geriatric home or something like that. Or hospital laboratories, definitely we are more prone to acquire the infection itself. Close contacts of cases with tuberculosis. And as I've already mentioned, the residents or employees in facilities where you have patients with tuberculosis being treated are the highest ones to get exposed to the disease. So as I've already mentioned, what we have to understand is the conditions that favor reactivation. HIV becomes the first one, and corticosteroid therapy was the second one till recently. Now what has come between immunosuppression and high-dose corticosteroids is your anti-TNF therapy that's been coming up a lot for conditions like rheumatoid arthritis, etc. And that's where we find the flare. Diabetes, malnutrition, cytotoxic agents, hemophilia, CKD, and silicosis. You have a condition called silicotuberculosis that comes whenever there is a malnutrition that's there, or cancers that could be there, any part of cancers. And of late, they're saying vitamin D deficiency and vitamin A deficiency are also associated with increased chance of reactivation of the tuberculosis. In brief about the pathogenesis, so as exposure would happen at birth or within the first few years, in India, we would get exposed to the disease, and there is a primary infection that could happen. This primary infection would generally heal, okay, and remain as latent in almost 95% of the people. And only when the immunity goes down or the patient ages, that's where it can get reactivated and we get secondary tuberculosis. So always please remember, primary tuberculosis is seen in children. It's not seen in adults, because all of us would have acquired the primary infection in childhood itself. And almost all of us are vaccinated with BCG. The primary infection is seen in children only. The classical primary tuberculosis is a manifestation of the pediatric disease. Now, can you get the manifestations of primary tuberculosis in adults? Can you get primary tuberculosis in adults? This is a common question that they ask you. You can get primary infection in adults immunocompromised, especially HIV. So in HIV patients, you do get manifestations of tuberculosis, which can be like the primary infection. Okay, so that is one thing that you have to remember. With the advent of HIV and the number of cases of HIV being increased, we do get still the Gons complex, etc., and the hilar lymphadenopathy, etc., even in adults that we see. Again, the primary infection, as we said, remains latent. 5% of the patients, it could progress and it can form miliary and disseminated tuberculosis. Now, this is what is prevented by giving BCG vaccination. So BCG vaccination, time immemorial, we have been using it, and almost all children do get BCG vaccinated at or within the first few days of birth. Now, the prevention effect of BCG vaccination is to prevent the serious complications of tuberculosis in childhood. It does not prevent tuberculosis. It's like the COVID vaccine that's been given now. COVID vaccine does not prevent COVID. It just prevents the severity of COVID. That's what has been studied. That is what has been told. But in tuberculosis, we have enough of data to say that BCG vaccination prevents the two important complications which could kill the child. One is TB meningitis, the other one is disseminated miliary tuberculosis. So that is what the BCG vaccination does. So as I've already said, it is the cell-mediated immunity and the type 2 hypersensitivity reaction, which is the major pathogenetic mechanism. So if there are any defects in the cell-mediated immunity or in the delayed hypersensitivity reaction, then the patients are more prone to develop the disease. So the natural history, as we said, the pulmonary tuberculosis is, the primary tuberculosis is mainly pulmonary. In a very small percentage, it could be GI or lymph node tuberculosis. There, it generally heals. So that's the classical Gons focus that you get, the subpleural focus in the upper lobe that's there with the hilar lymph node and the lymphatics that together forms the Gons complex. And 90% of it heals with calcification, sometimes fibrosis, sometimes it could ossify also in severe forms. 10% could progress, and it can go on to become disseminated in children. It could be miliary, where it spreads all over the body, almost all organs can get involved. And whenever the latency remains, I said 95% of them remain latent, that's there, it can act as secondary tuberculosis that could occur in adults that could happen. So this would be the natural process of the primary tuberculosis that could happen. So whenever you have a patient who is supposed to be infected with tuberculosis, this is the general algorithm I'm telling about. It's not the specific for any of the types. So if you have a negative IGRA, that is your gene expert or result, or the tuberculin skin test that is there results, so does not develop latent tuberculosis infection or TB disease. So if somebody is negative for a tuberculin skin test or a interferon gamma assay, IGRS stands for that. So these patients are not infectious. Supposedly it's positive for these two things and there is an abnormal X-ray, the symptoms are there, becomes culture positive. This is the patient who can get infected. So just a positive IGRA or a TST does not mean the patient is infectious. The patient becomes infectious only if it is sputum positive. So even if patients have latent tuberculosis, they are not infectious. That is what we have to remember. So coming on to the primary tuberculosis, the infection seen in an unsensitized host. So initially in children and the classical Gons lesion and complex. Rarely it could be ileal lymph nodes that could be there and ileal tuberculosis. Tonsils you could have, and the tonsillar lymph node, that's a jugular-digastric lymph node can occur. And very, very rarely the skin can be a primary site of primary tuberculosis. So please remember the 4 sites. It is almost 90 to 95%. It's the lung. Then you have the intestines, the tonsils, and the skin. These are the 4 sites where you can get primary tuberculosis. All of the sites are either secondary or post-primary. So please, this is an MCQ. They ask you what are the sites of primary tuberculosis. These are the 4 sites of primary tuberculosis that could happen. So the lung is the commonest location that we have. So as we say, the Gons focus that's there, which could be located subpleurally, and usually it is located at the lower part of the upper lobe or the upper part of the lower lobe. That's the segment that's located there. And because that can be associated with the regional lymphatics and the lymph nodes, that becomes the Gons complex. Once it undergoes calcification and fibrosis, and that is seen on an X-ray as a calcified lymph node with a calcified lymphatics and a calcification in the lung, that is called as a rank case complex. So majority of the Gons flocculus would generally heal with calcification. So what would be the symptoms? Majority are asymptomatic. They may have just fever that could be there, and since they would have got exposed to a person who is sputum positive, you might do a tuberculin test and that can come positive. Patients can have slight dry cough, failure to gain weight, reduced appetite, usually in children, that's as I said. They may not have any major clinical features that could be there. Only crepitations could be heard as a specific feature that you see, that is the crepitations. And one specific type of crepitation that is seen in active tuberculosis is what we call it as a post-tussive crepitation. That means the crepitations are not present before the patient coughs. And once the patient coughs, the crepitations appear. Now, this is very specific. In the earlier days when investigations were possibly not available, this is where they used to make the diagnosis of tuberculosis by doing something called as a post-tussive crepitations. That was specific in that. One important thing which still is considered as erythema nodosum, which we do find in adults also, is erythema nodosum. This is primary tuberculosis. Again, on the shins, you get painful lesions. It's most often in the skin. It's nothing but a type of paniculitis. So inflammation of the subcutaneous fat. We could have various types of paniculitis. Erythema nodosum is one of the common things. Please remember, erythema nodosum is one of the very common manifestations that we do encounter in adults that you see. How do you diagnose? It's the sputum that we do and the sputum or the laryngeal swab in children. And again, in children, since they do not get the sputum out so well, we may have to do something called as a fastic gastric washings because they would swallow the sputum. So early morning, you can put a small rice tube or gastric lavage and then take the sample, you might get the sputum that could be there. AFP could be there. This is what I said about the erythema nodosum, very common finding. And you find that the erythematous raised discrete nodular lesions, most often on the shin. This is a type of paniculitis. In India, the most common cause is tuberculosis. But please remember, if they ask you about erythema nodosum as a short notes or the causes of erythema nodosum, tuberculosis is the first one. Then you have the 3 S's. Number 1 S is streptococcus. The second S is sarcoid. And third S is sulfonamides. So streptococcus, sarcoidosis, and sulfonamides can produce. Many other drugs can also produce. In India, Mycobacterium tuberculosis, Mycobacterium leprae. You have something called as an erythema nodosum leprosum, which is a lepra reaction where you can get it. Erythema nodosum can be associated with inflammatory bowel disease also. But practically, if you see erythema nodosum in India, they end up putting them on anti-tubercular therapy because it is very difficult to prove the disease in such a condition. You may do a MAN2 which may come plus minus there. You may not get a really 10 millimeters and about MAN2, but even without that, we can put the patient on treatment. The IGRA can be done, but whenever there is erythema nodosum, it means it's one of the primary tuberculosis that we see. The chest X-ray, as I've described already, you might get the hilar adenopathy and the Gons focus, the classical. Now this X-ray, if you see carefully, it's you can see this is the hilar part here, and this is the subpleural calcified lesion here, and this is the lymphatics which you can see. That's the healed complex that you see there. And you find certain infiltrates. You can find that there are certain infiltrates which is the upper lobe. Possibly it's a post-primary that you see. You may just find a hilar adenopathy, and remember the most common cause for unilateral hilar adenopathy is tuberculosis. Unilateral hilar adenopathy in India is tuberculosis is the most common cause that you could see. Fate of the Gons locus, I have already discussed. It heals by calcification, so that's a Rankes complex. But it can spread, and that is what we call it as the progressive pulmonary tuberculosis. So it could go to the progressive pulmonary tuberculosis where it progresses and it involves the rest of the lung. Transbronchial spread can occur. The caseous material which comes out can spill into the bronchus and it can go and spread to the other parts of the lung. Hematogenous spread, as we said, in miliary tuberculosis and the lethal form, that is the TB meningitis. Lymphatically, it can spread to the local pleura. It can go to the mediastinum. It can go to the pericardium, and it can disseminate it to other organs also. So that would be the fate of pulmonary primary tuberculosis. Some common questions they ask you when you have a hilar lymph node that is there, it generally compresses the middle lobe, and we call something called as a middle lobe syndrome. Okay, middle lobe syndrome, or otherwise called as a Brock syndrome. So when there is a hilar lymphadenopathy and it compresses there, so it produces a collapse of the bronchus and the middle lobe that is there. The secretions can incipate there, and that can result in bronchiectasis later. So what we call it as the proximal bronchiectasis, or one of the common complications that you could get, that is the proximal bronchiectasis, that is the middle lobe syndrome. Also, sometimes it can produce obstructive emphysema and the air trapping can occur. And sometimes you could have the bronchiolith that can obstruct a bronchus, and that can manifest as hemoptysis. So middle lobe syndrome or Brock syndrome, again a classical feature of primary tuberculosis. Also remember the MAC, that is the Mycobacterium avium cellular, can also cause something like this. That is not called as a Brock syndrome. I think we have discussed it in one of the earlier classes. It's what we call it as the Lady Windermere syndrome, where you have proximal bronchiectasis the patient can come with. Again, that's more common with MAC, Mycobacterium avium cellular. So coming on to secondary tuberculosis, this is what we see in adults. It's the TB in a previously sensitized individual. So already sensitized individual. The most often source is the endogenous reactivation. So it could be reactivation of the primary lesion. It could be hematogenous spread. Rarely the patient is getting a second infection. So it's always a reactivation that could occur. And the secondary tuberculosis, again, it has the predilection for the upper lobe. So predominantly upper lobe, as we say, the apex of the lung gets involved there, and you get fibrosis of the upper lobe that could be there. Again, the spread of the secondary tuberculosis can occur everywhere. It is more rampant in spreading. It can have local spread where it can go to the pleura, producing pleural effusion, empyema, and pleural fibrosis, what we call it as a fibrothorax. It can cause tuberculous pneumonia. It can go to the larynx. It can spread into the GIT. Can have miliary that could happen, lymph nodes, and it can again spread to almost all the organs which we discussed. Please remember, one of the common abdominal organs where the tuberculosis spreads is adrenals. Adrenals is one thing that is commonly spread both in primary and secondary tuberculosis that could be there. Also the genitourinary, the testis and the ovaries can also get involved. The fallopian tube can get involved. Bones can get involved. Renal system can get involved. The spine can get involved, and you could have tuberculous meningitis also. So that's the fate of secondary tuberculosis. Again, it will heal with fibrosis, and this is where you get the cavities, or the thick-walled cavities, thin-walled cavities, all those things that you see in adult tuberculosis that you get. So this is what happens. So it could spread anywhere. It could form a tuberculous pneumonia. It can spread to the pleura that's there. It can spread to the distant organs, and it can also spread to the intestine and brain. So the general symptoms would be the same. Again, the patients may have no specific symptom related to the lung. The fever with evening rise of temperature, that's the classical, a low grade fever. There's a little difference where they say whether it's a remittent fever or it's a continuous fever. Remittent means the fluctuations are pretty high. That does not happen in case of tuberculosis, though the classical description is a remittent fever only. Late afternoon and then subsiding by the evening. Night sweats is what is seen. Weight loss is something which you should always remember as an important feature of tuberculosis. Unexplained weight loss, you have to rule out tuberculosis. So fever may not be a predominant feature. Respiratory wise, they can develop symptoms, cough. Again, as per the definition, any cough which is going on for 2 to 3 weeks, you should be evaluating for tuberculosis. Hemoptysis, various causes, we'll discuss that. And the classical sputum that is produced, again remember, tuberculosis does not produce large amount of sputum, because large amount of sputum is involved whenever the alveoli get inflamed, the inflammatory exudate fill the alveoli. Tuberculosis, the problem is not in the alveoli there. So you get mucoid and not a very scant, a mild sputum. And the classical sputum is described as a pneumilla sputum. So when the patient coughs it out into the container containing water, it takes a shape of the coin. So that is the classical description. And they have streaking hemoptysis. They can have pleurisy, they can have other features also. Breathlessness. So remember, breathlessness can occur in tuberculosis in 2 situations. One is when the tuberculosis is extensive, where more than 3 lobes of the lung is involved, or there is tuberculous pleural effusion. So otherwise, breathlessness does not happen in tuberculosis. So please remember, if there is breathlessness in tuberculosis, it's either tuberculous pleural effusion, which is common, or there is an extensive tuberculosis that is there. Whenever there's a localized obstruction of the bronchus, either due to a lymph node or due to a bronchiolith, you could get a localized wheeze, and there could be other manifestations that you could get. One important thing that I would want to say is what I told you about the post-tussive crepitation, which could be seen in primary also. One more feature you could get is the cavernous bronchial breathing. Now here in this secondary tuberculosis, you get cavities that are formed, and these cavities are thin-walled cavities. And you get a classical finding called as post-tussive suction. Now, what does post-tussive suction mean? Remember, the cavity is there which is communicating with the bronchus. The surrounding lung is normal. When the patient coughs, the entire secretions from the cavity come out and the cavity becomes empty. And since it's a very superficial cavity and the wall is not fibrous, it collapses. So you auscultate possibly the infraclavicular area. That's where you can get this commonly because upper lobes are involved. You can get a cavernous bronchial breathing. And whenever you get a cavernous bronchial breathing in the exams, you're supposed to check for post-tussive suction. Because post-tussive suction means it's a superficial collapsible cavity. That is the hallmark of active tuberculosis. You will get active tuberculosis only. You do not get post-tussive suction in healed cavities. Now, once the tuberculosis heals, there is fibrosis that is there. The cavity becomes thick-walled and that will not collapse. So post-tussive suction is a feature of active tuberculosis. Again, a very common question they ask you, what are the prerequisites for post-tussive suction? Number 1, you should have a superficial, thin-walled cavity. Number 2, the surrounding lung should be normal. Number 3, the cavity should be communicating with the bronchus. Cavity should be communicating with the bronchus. So superficial, thin-walled, collapsible cavity, if it is present, we can get the post-tussive suction. So remember, post-tussive crepitations as well as post-tussive suction are characteristic feature of active tuberculosis that you could get. As it heals, it produces fibrosis. Majority of tuberculosis heals with fibrosis. So you'll have features of volume loss on one side that will be there. So trachea will be shifted, the mediastinum can get shifted, the movements will be decreased, and skeletal changes also you can get as a sequelae. What are the complications? Again, a very common question they ask you, what are the complications of tuberculosis? So in the lung, it can produce pleural effusion, it can produce pneumothorax. Massive hemoptysis can happen. Now, hemoptysis in tuberculosis can occur due to various causes. It can be to the activity itself. There is an inflammation there, or the cavity, in the cavity wall, you could have aneurysms that develop from the bronchial vessels. So the bronchial vessels can have developed these aneurysms. So they are called as Rasmussen's aneurysms. Now these are dangerous because bronchial circulation is a systemic circulation. It's a high pressure system. If that ruptures, the bleeding will not be from the pulmonary. The bleeding will be from the bronchial circulation. So the patient can die due to a massive hemoptysis if something like a Rasmussen's aneurysms can rupture. Other causes of hemoptysis is there could be a lung abscess in the cavity, there could be a aspergilloma in the cavity that could occur, and there could be recurrent infections, and that can produce. Sometimes the calcification, what we call it as a bronchiolith, that can also produce hemoptysis. So you could get calcification, you can get fibrosis and compensatory hyperinflation, and the cavities can get infected, that can get infected lung abscess, aspergilloma can come. Sometimes you could have a bronchopleural fistula, and the scar of fibrosis can result in bronchogenic carcinoma. Please remember, the scar carcinoma in the lung is not squamous cell, it is adenocarcinoma that you can get. The non-pulmonary complications, you see, the empyema can track out onto the subcutaneous plane, what we call it as the empyema necessitans. So you'll find that there is a swelling in the chest, and with each coughing, that size increases. Very characteristic feature of empyema necessitans. Spreading of tuberculosis into the other organs, very important. Remember, Addison's. One of the commonest cause of Addison's in India is tuberculosis. So patient comes with a low BP and has hyponatremia and hyperkalemia and some pigmentation. You should always suspect tuberculous Addison's. It can produce enteritis, anorectal disease, laryngitis, one of the important diseases. Amyloidosis, any chronic disease can produce amyloidosis. The patient can have nephrotic syndrome. One important, not a very common, but yes, it is seen in some percentage of patients, is what we call it as a Ponson's rheumatism. The Ponson's rheumatism is a polyarthritis. It's an immunological mediated polyarthritis seen in tuberculosis. You get the joints of the hand that gets involved. So they would have pain, arthralgia, some amount of stiffness, but no deformities. Ponson's polyarthritis. They can be prone to venous thromboembolism, also that can happen due to that. So as I've already discussed, this is a very common question they ask you in your viva. What are the causes of hemoptysis in tuberculosis? The first important thing I've told you is the Rasmussen's aneurysm there. They are nothing but the blood vessels which are traversing the cavity can get inflamed and necrosis, and these can rupture, and these can rupture from the bronchial side, so they can happen. Sometimes the cavity, the vessels can get inflamed due to the antigen antibody reactions, and that can also cause bleeding. Tuberculosis of endobronchial origin, that can erode the bronchus there, and the vessels which are located in the submucosal regions, they can bleed from that. Slumping from the granuloma can result in bleeding. You have something called as open healed cavities. Again, a very common viva question they ask you is what do you mean by INH cyst? INH cyst is where you have the cavities which are there. Once the patient has been started on treatment, these tuberculosis would heal, but the cavities will remain open. So you will have a cavity that's there, but this patient will be sputum negative. This is what we call it as an open negative syndrome. So when you auscultate, you will find a cavity, you'll get a cavernous bronchial breathing. You take an X-ray, you'll find a cavity, but the sputum is negative. So this is secondary to the INH chemotherapy. That can also cause that. So again, you can have aneurysms there. Post-tubercular bronchiectasis, one of the most important complications which we encounter, and that can produce hemoptysis. Again, you have a variety of bronchiectasis called as bronchiectasis sicca. Remember, tuberculosis usually involves the upper lobes. So upper lobes are by far, they are draining directly. So the secretions do not remain in the upper part there. So they generally come with only hemoptysis. Aspergilloma, very common. Bronchioliths are common. And as I discussed about the scar carcinoma. So these are the various causes of hemoptysis in tuberculosis. Coming on to the investigations, the features that could be there in active tuberculosis. So this is what you see in an active tuberculosis. Remember, thin-walled cavities. So thin-walled cavities, patients can have thin-walled cavities and fluffy shadows, or what we call it as an interstitial shadows. What you see here, the interstitial shadows here, fluffy shadows that you see there. and the thin-walled cavities. So this suggests active tuberculosis. Also, tuberculous pleural effusion can be there. So that's also a sign of active tuberculosis. So here, if you see here bilateral shadows, these are the fluffy shadows, thin-walled cavities can be seen there. So again, this is active tuberculosis. What are the signs of healed tuberculosis? Again, remember the signs of healed tuberculosis: calcification, fibrosis, calcification, fibrosis, and volume loss. If there is a volume loss, that could be there. So those are features of healed tuberculosis that you could get. Cavity is by far the most important thing that you can get. So if you see this X-ray here, you're finding that there is bilateral shadows, and you see this fluffy shadows, and in that you find this thin-walled cavities multiple, and this is active tuberculosis, again extensive tuberculosis. Possibly this patient is immunocompromised. This is what I was talking about, the thin-walled cavity. You can see this thin-walled cavity that's there. Rest of the lung is normal. So this is also tuberculosis that you could see. Again, an important feature, you can see that there is a lot of fluffy shadows there, cavities are there. On the right side, you find that there is a visceral pleural line and a air fluid level. You can see this hydropneumothorax. Again, a very common finding in tuberculosis. You can get pleural effusion and hydropneumothorax. Again, a feature of active tuberculosis that you have to see. Again, on a CT chest, okay, sometimes maybe you may not get classical X-ray findings. You can get CT chest and a classical appearance, what is called as a tree in bud appearance. Please remember, tree in bud appearance is classically seen with bronchiolitis in children, but in adults, tree in bud appearance, you can see this tree in bud appearance classically seen in tuberculosis, that you could get that. You could get a PET CT and you can find the actual lesions in the PET CT. Okay, if the patient, if you're not able to localize it on any of the images, you can do a PET CT and you can find the active lesions that could be there. So that's about the clinical manifestations of pulmonary tuberculosis. Any queries so far, or will continue? Any doubts or clarifications?
I think we can continue, sir. As of now, there are no questions.
Okay. So coming on to the investigations, that the laboratory investigations that we do for tuberculosis, we are talking about the pulmonary tuberculosis. Sputum is the most important. Earlier, they used to ask for 3 samples. Now, what is advised is the 2 samples that is there. So 2 samples of sputum, one is a spot and one is the early morning sputum. If the patient has difficulty in getting out sputum, you can induce the sputum by giving saline, or if the patient, you have a strong suspicion, you can do a bronchoscopy and do a bronchoalveolar lavage. In children, as I've already told, you can do a gastric aspirate also in children. For extrapulmonary tuberculosis, you have various other samples. The CSF could be the pleural fluid, ascitic fluid, biopsies, urine. All this can be used for the diagnosis for extrapulmonary tuberculosis. For your pelvic endometrial disease, you can do a biopsy from there. And blood is not a very strong feature. Various tests are there in the blood, but none of them are very strongly sensitive or specific for diagnosis of tuberculosis. So as I've already said, the AFB is the one which you see the acid fast staining, and you do the staining and you can localize the bacteria that's there, and based on the positivity, we say it's a sputum positive test that is there. The various grading of samples, I won't go by this. It's used for making whether the patient is improving or not. Sputum culture. Now this is the traditional culture that is there. You have the various medias which are available. The Middlebrooks media is there. The Bactec is there. The Lowenstein Jensen is there. So various medias are available. The problem with this is tuberculosis takes a long time to culture. It takes almost 3 to 4 weeks for the culture to available. What is available now is something called as a Bactec, where you have the system that is there, where you have the labeled probes that would come there, and within 4 to 8 days we can get that. If it's a positive growth, we can culture it. That's the Bactec that's come, but again that takes around 4 to 8 days. So culture is not very feasible, and culture is done especially to do for the sensitivity pattern. We still do the cultures, otherwise cultures are not. Now what has come up, and as per the guideline also, all patients who have sputum positivity or even sputum negative case, which your suspicion is strong, they are supposed to undergo the nucleic acid amplification test, what we call it as a CBNAT. That's the cartridge based nucleic acid amplification test. And you have the gene expert or the MTBRF test that is there, which not only identifies the organism, but also identifies whether the patient has rifampicin resistance that is there. It's very important because this would require a very, very small amount of organism that's present, even 1 to 10 organisms per ml. You will get a positive result because this is a gene amplification that is done. Also, it detects resistance to rifampicin, and if the patient is rifampicin resistant, we do call it as MDR tuberculosis. Now, for the line probe assays, line probe assay is done for line probe assay is done to detect the resistance for the second line drugs usually, or even sometimes isoniazid, etc. We do the line probe assays. You have the first generation line probe assay and the second generation line probe assay. These are also available now, basically to detect the drug resistant pattern. Some of the other methods that they ask you in your vivas or OSCEs, one is called as the MGIT. That's nothing but the Mycobacterium growth indicator tube. So here the growth is detected by non-radioactive detection system using a fluorochromes for detection and drug screening. So this is what we call it as the MGIT tube that we use. And this is again the HPLC method is used for the detection of that. And you could do IgM and IgA, ELISAs can be done, but then the sensitivity and specificity is very low. That's done from the blood. You have the Mycobacterium specific phages, the reporter pages that are there, which detects the luciferase gene that is there, and it can be used for identification of drug resistant isolate. This is not come into vogue for general practice, but this is used for various research purposes. The other investigations, laryngeal swab, early morning gastric lavage, bronchoalveolar lavage, all of them you can subject to the same test which we have discussed. Tuberculin test, again, it's not a diagnostic test. Remember, tuberculin test is a test to see whether the patient is has got infected. Does not mean it diseased. So tuberculin test is not a feature of active tuberculosis. It just means the candidate, the person is infected. Drug sensitivity testing is mandatory because the MDR and the XDR pathogens are increasing. So whenever we do the drug testing. So anybody who is positive undergoes the CB-NAT, you get the rifampicin resistant. And if it is further resistant, then we go on to the line probe assays that are done. And based on that, the patient is classified as MDR or TDR that is there. So various methods are there. What is classically used now is the line probe assay only. That is what is used by the RNTCP. The line probe assay itself is there. But there are other methods also. The traditional Lawrence changes method, the bactimetric that is method, the nitrate reduction, the ligase chain reaction, all can be used for drug sensitivity testing. So those are the methods that we do, and that is how you diagnose the tuberculosis. So let's go on to a short section on what we mean by latent tuberculosis. Now, what do you mean by latent tuberculosis? Now, latent tuberculosis is most individuals develop are infected and they develop cell-mediated immunity to the bacteria. They do not have active disease. This is what we call it as latent tuberculosis. It remains in them, and sometimes it could heal. And the problem with latent tuberculosis is it can get reactivated. The risk of progression to active tuberculosis is around 5 to 10%. The highest risk of progression occurs in the first 2 years of the infection. And how do you detect this? The two important tests that we have. In India, we do the tuberculin skin test and the interferon gamma release assay, the IGRA, it's available. But in the West, in the US and in the UK, IGRA itself is the first test that we do for detection of latent tuberculosis. So the tuberculin skin test, again, a very common short notes, both in medicine, pediatrics, what is done for detection of tuberculosis, latent tuberculosis. Now, tuberculin skin test is an type 4 hypersensitivity reaction that we are giving. That is a delayed hypersensitivity reaction that we are going to test. And we are going to use the PPD, that's the purified protein derivative. And what is used is the PPDS that is used. And using the MAN2 syringe, that is your MAN2 syringe, 1 cc syringe that is there. And there is a 5 international units that is given there. And then you check. Very importantly, you have to raise a wheal that is there. So it's given intradermally, a wheal should be there. A papule should be developed around 5 to 6 millimeters should be developed when you inject this. The reading usually ideally done at 72 hours, but you can do it at 48 hours. And what we are going to measure is the induration. So please remember, it's not the erythema alone, it is the induration that we are going to measure, the transverse induration, that's what we are going to measure. And induration more than 10 millimeters in diameter, then we consider it as positive. More than 5 millimeters is considered positive if there is an immunocompromised state. Supposedly the patient is an HIV patient or any other immunocompromised state, then we consider it as more than 5 millimeters is positive. Or if the patient has a recent history of exposure with an active patient tuberculosis, then possibly the reaction would develop in a little later stage. So in such patients, possibly we can consider 5 millimeters as positive. Also, if a patient is organ transplant or on immunocompromised therapy, such cases we can still consider 5 millimeters as positive. Supposedly you have an X-ray which is classically showing tuberculosis, sputum is negative, and then you have a MAN2 test that we do, which is around 6 to 7 millimeters, you can still consider as positive. Again, please remember, it does not mean disease, it just means there is an infection. So it can be used for diagnosis of extra-pulmonary tuberculosis. Sometimes you have choroidal tuberculosis, or maybe there is lymph nodes which are there which are not accessible for biopsy, or you have choroiditis or miliary tuberculosis, miliary shadows are there and biopsy is not feasible. In such conditions, if your tuberculin skin test is positive, you can consider as a diagnosis. In children, definitely we can consider as a diagnosis there is there. Also, please remember, sometimes you can get false positive reaction in atypical mycobacteria. Atypical mycobacteria disease, you might get false positive reaction. Also, you can get false negative reaction. If supposedly somebody is on steroids, somebody is malnourished, and somebody has HIV, you may not get a 10 millimeter induration in that. Also, one thing we have to remember is what we call it as a hyperreactive MAN2 reaction, where at 48 hours to 72 hours, you not only find an induration, you find it ulcerative. So it's like a very much severe reaction, which is classically seen with lymphoma. More than tuberculosis, you might get a hyperreactive MAN2 in lymphoma. So MAN2 test has wide significance that could be there. IGRA, this is the other method that we use for detection of latent tuberculosis. IGRA is the method that we use for the detection. Again, remember, it has a sensitivity of around 80%. The specificity is 98%. Wonderful test, but the sensitivity is 80%. That means 20% can still miss it. So the quantiferon gold, that's the test available in India at present. It's an ELISA-based test that is there, which detects the antigen that is there. So that's how about the latent tuberculosis. Coming on to the diagnostic algorithm of pulmonary tuberculosis, this is going by the latest guideline. 2018 was the last update that we had. So whenever we have patients who have presumptive TB patient, do a smear examination, do an X-ray. This is mandatory. So if the smear is positive, then we can straight start them on tuberculosis therapy. Okay. All patients who are smear negative, or you have people living with HIV, you have to directly go on to do the CBNAT. That's what is recommended. The CBNAT, it will detect both the tuberculosis as well as the resistance. That is how you can diagnose. Now, if the chest X-ray is having shadows, sputum is positive, there is nothing, you'll have to start the patient on treatment. If the sputum is negative or not available and X-ray is positive and your clinical suspicion is high, you can do the CBNAT. And if the CBNAT detected MTB, you can start the patient on treatment. If the CBNAT is negative or the CBNAT results is not available, then you can consider alternate diagnosis. But if your clinical suspicion is strong, you can consider as clinically diagnosed tuberculosis. So finally, based on the guideline, you have two types of tuberculosis that are there. One is microbiologically confirmed tuberculosis, one is clinically diagnosed tuberculosis. Microbiologically is either sputum smear or CBNAT positive. CBNAT positive. Please remember, all patients with people living with HIV, if you have suspicion of tuberculosis, all of them do undergo CBNAT. And as of now, most of the patients who are you're doing a sputum test and the smear, even if it is negative and the clinical suspicion is high, you can ask for a CBNAT there. So that's how you make the diagnosis. If supposedly you find the resistance pattern is rifampicin sensitive, then we can start the standard regimen. If it is rifampicin resistant, then you can straight start them on the MDR regimen. And if it is indeterminate, then we will have to possibly do a line probe assay for detection of the resistance patterns that we have to do. So the same thing, if a patient has persistent fever, cough for more than 2 weeks and weight loss that is there, you can do the CBNAT in the patient. If MTB is detected, then it directly becomes a microbiologically confirmed tuberculosis. If the X-ray is suggestive and tuberculosis is not detected, your sputum or the CBNAT does not detect, then it becomes a clinically diagnosed. So these are the two sort of cases. Treatment is same for both of them. If it is microbiologically confirmed or if your clinical diagnosed tuberculosis case, treatment remains the same for both. Before we go on to the actual treatment, a brief about extra-pulmonary tuberculosis. Again, 15 to 20% of immunocompetent patients and 50% of patients with TB with HIV develop extra-pulmonary tuberculosis. So almost 50% of patients with HIV develop extra-pulmonary tuberculosis, whereas 20% of immunocompetent patients do develop extra-pulmonary tuberculosis. That you have to remember. The commonest sites are the lymph node, the pleura, the GI tract, the bones and joints, peritoneum, and pericardium. Please remember, tuberculosis can involve any part of the body. The only three sites which is supposedly spared by the tuberculosis is the hair, the nail, and the enamel. So these are the three sites supposedly spared from tuberculosis. Otherwise, every other part of the body can get involved. So the hair, the enamel, and the dental enamel, and the nails. These are the three sites where the tuberculosis has not been reported. So the most important sites that I've already described, the pleural tuberculosis, the lymph node tuberculosis, any lymph node in the body can get involved. The skeletal system starting from the peripheral to the vertebra that could be there. You get the pod spine, it could be there. TB hip can be there. Nervous system tuberculosis has the form of tuberculous meningitis. You could have tuberculomas, you could have vasculitis. GI tract tuberculosis, the ascitic tuberculosis, the pericardial tuberculosis, genitourinary, adhescence, a very important thing. And then you could have skin tuberculosis in the form of either erythema nodosum, or you could have tuberculids, you could have lupus vulgaris and scrophulodderma. So as I said, the classical is the tuberculous lymph node. So you could see here the lymph nodes which has caseated and come out, it's opened out there in the skin lesion as you classically see it is the sinuses that are produced due to that. And the classical lymph nodes that are there in tuberculosis, posterior triangle lymph nodes can commonly get involved. But if it is through the oral route, the tonsillar route, the most common lymph node that is there is the jugulodigastric lymph node that you get involved in tuberculosis. The characteristic appearance, matting of lymph nodes, that is due to the periadenitis. Periadenitis, inflammation of the capsule of the lymph nodes, so they become sticky to each other. Very characteristic. It's very rarely seen with lymphoma. Whenever you find matted lymph nodes, it is always tuberculosis that you're doing. Also remember, very rarely in tuberculosis you can get hard lymph nodes also. So tuberculous lymph nodes, you can do an FNA, you can do a biopsy, and then rule out immunocompromised state, and you can start them on treatment. Coming on to the tuberculosis of the bones, you could have peripheral joints that could be involved, you could have hip joints that can involve, and the classical tuberculosis of the spine. Very important, remember, tuberculosis always involves the vessels that is at the interdiscal area. So two vertebrae are classically involved. You can see that here, and they get the classical gibbous deformity that is there. And the tuberculous spine, you can have an abscess form there, you could have a cold abscess that is could form there. It can track down anteriorly through the psoas. It can cause compression on the spinal cord, and it can disseminate also. Also in the spinal cord, tuberculosis can cause myelitis, and it can cause arachnoiditis also. So you could get the psoas abscess very characteristically, it tracks down and comes in the front. You can see that. It can also involve the various other parts of the spine. Next, coming on to miliary tuberculosis, it's a type of disseminated tuberculosis that you find. Miliary tuberculosis is the characteristic thing, which is one of the types of disseminated. So it is usually hematogenous spread that is there. The patient can come with organomegaly, lymphadenopathy, and very characteristically, if you find choroid tubercles, one of the important things that you have to remember, whenever a patient comes with PUO, pyrexia of unknown origin, lymph nodes are there, and then there is hepatosplenomegaly, and there is weight loss, and there is a exposure to tuberculosis. So always look at the fundus. You might find the classical choroid tubercles. You can diagnose the patient. Sometimes the patient may be some variety called as a non-reactive miliary tuberculosis, usually seen in elderly patients where they are extremely ill, and they rapidly progress to death. So it's something like a tuberculous septicemia, where they have a very, very severe form of miliary all over the body. On postmortem, you would find that. So it's a rare form that you could see. So this is the classical miliary mottling. You can see on the X-ray. You're finding discrete nodules that are there, 1 to 3 millimeters in size, and that's present in all over. Again, a very common X-ray that is kept for you in your exam, in your vivas, that's asked, what is miliary mottling? So miliary mottling is classically seen with miliary tuberculosis. You can also get miliary mottling in tropical pulmonary eosinophilia. You can find miliary mottling in lymphangitis carcinomatosis. Supposedly a patient has CA breast in the past, or the patient has thyroid malignancy possibly. They can have miliary mottling, and that's secondary to lymphangitis carcinomatosis. You can find miliary mottling even in sarcoidosis, very important. You could get this hilar lymph nodes here and miliary mottling, that's classically in sarcoidosis. Rarely disseminated fungal infections like histoplasmosis, coccidioidomycosis can be get. Again, remember HIV is common. In HIV, pneumocystis zerovici pneumonia can produce miliary mottling. Pneumocystis zerovici pneumonia in HIV patients can produce miliary mottling. You can get miliary sort of mottling, but the size is a little more. That's classically in case of pneumoconiosis. Chickenpox pneumonia also after healing of that could be there. Chronic mitral stenosis, you get classically something called as a hemosidrosis, where you can get that. And the drug which can produce miliary mottling is nitrofurantoin. So this is the differential diagnosis for miliary mottling. Please remember, this is asked for you in your vivas, in your theories, as well as sometimes in the practicals, they can ask you about miliary mottling. And remember, the size of the miliary is 1 to 3 millimeters usually. So we can do the X-rays, you can do the biopsies also, you can do the bronchoalveolar lavage. Again, remember, miliary tuberculosis, sputum negativity. You do not get sputum positive in miliary. So you can see this, the lung is studded with miliary, but sputum positivity is very rare. 1 to 3% can become positive. Sometimes the miliary shadows or the miliary lesions can coalesce and you can get sputum positivity. Otherwise, you do not find sputum positivity in miliary that often. You can do a PET CT, you can do a direct lung biopsy, and very importantly, alkaline phosphatase elevated. Alkaline phosphatase elevated. That's a indication that the liver is involved diffusely. Some sort of a liver granulomas could be there. A liver biopsy can be done. Also, bone marrow biopsy also will tell you that the marrow is also involved in such cases. So that is helpful in that pattern. Next, coming on to tuberculous pleural effusion, again, a very, very common cause of pleural effusion, exudative pleural effusion that you find in India is tuberculous pleural effusion. It could be right side, left side, bilateral also, you could get it. In HIV, you can get pericardial pleural effusion also, and you can get loculated effusion. Loculated effusion in India, by far the commonest causes tuberculosis itself. The mechanism of pleural effusion in tuberculosis, wide varieties. It could be an immunological reaction. So it could be a hypersensitivity reaction that could be there, or it could be direct spread. Okay, it could produce something called as a tuberculous empyema. And sometimes you could have a bronchopleural fistula that could be created, which produces a hydropneumothorax. The classical pleural fluid, so straw colored or amber colored, you can get that, and it's an exudate, predominantly lymphocyte, and AFB generally not very commonly seen. Culture can be positive in around 50% of the patient. ADA is elevated, and ADA level more than 40 could be diagnostic, more than 80 could be very much suggestive that could be there. If ADA is negative, then it possibly rules out tuberculosis. You can do the CBNAT from that fluid also. Coming on to the next common, abdominal tuberculosis. So abdominal tuberculosis could be at various forms. It could be gastrointestinal tuberculosis that could be there. It could be peritoneal, it could be abdominal nodes, it could be solid organ. So it could be of any form. Again, a very important long question it's asked for you in surgery usually. Classify abdominal tuberculosis and discuss the various patterns. GI tuberculosis, most common ileum can get involved. Other parts also can get involved. You could get an ulcerative form, you can get a hyperproliferative form, and you could get either chronic diarrhea, you can get GI bleeds, you can get intestinal obstruction. So all those features can be there in GI tuberculosis. Peritoneal tuberculosis, you could get the ascitic form, or you can get an encysted form that could be there, and rarely you could get a fibrotic form. When palpation of the abdomen, you get the classical dovey abdomen. doughy abdomen appearance. Please remember one of the causes of ascites where you do not have pedal edema, what we call it as an ascites precox, is abdominal tuberculosis. Also remember, one of the other sites where tuberculosis can be there and it can produce ascites precox is constrictive pericarditis. So constrictive pericarditis, you get only ascites as a form, and most common cause of constrictive pericarditis is tuberculosis. Solid organ tuberculosis, it could be the liver, it could be the kidney, it could be the spleen that could be involved, and adrenal tuberculosis. So very important. Always look for hyponatremia in a patient with tuberculosis. You have to suspect Addison's as an important cause. TB mesenteric lymph nodes, again common as a part of all lymph nodes, or it could be part of isolated. Quite difficult to differentiate unless you do a biopsy and see the granulomas. It can occur due to HIV. Similar lymph nodes can you get in a lymphoma also. So if it's just isolated mesenteric lymph nodes, it becomes difficult to diagnose unless you biopsy. Genitourinary tuberculosis, tuberculosis of the genital urinary tract. You can get orchitis, etc. But the kidney can get involved in various patterns. I think in surgery they would have discussed this, where you have a papillary ulcer, the cavernous pattern, the pyonephrosis pattern, the putty kidney, and the miliary pattern, and the pseudocalculi pattern, etc. would be there. The CNS tuberculosis, by far very important, especially in immunocompromised patients. So it could cause the meningitis, it could cause tuberculomas or the space occupying lesion, or it can produce vasculitis also. So primary source is the lung itself most often, and the dissemination can occur in young children or an immunocompromised patient. And it could produce leptomeningitis or pachymeningitis. It can produce tuberculoma, it can produce cerebritis, it can produce encephalopathy rarely, abscesses, and very important, you can produce vasculitis and the patient can develop stroke also. You have to remember that. The classical finding, you do the CSF, you will find something called as a cobweb appearance. The protein will be elevated, the sugar will be low, the opening pressure will be elevated, and if you keep the CSF, you will find the classical cobweb appearance. AFB in the CSF is pretty rare to get. You can do the gene expert and ADA. That's how you can diagnose tuberculosis of the CSF. This is the classical tuberculomas where you find multiple ring enhancing lesions that are there. There's no specific predilection for, but cortex is usually spared in tuberculosis. It could be in the subcortical regions, it could be in the cerebellum, it could be in the basal ganglia region, it could occur in any other site. So that's about the tuberculosis of the extrapulmonary. The female genital tract and the main genital tract also can get involved. One of the important causes of infertility is due to the fibrosis that can affect the fallopian tubes, and that can cause that. So that problem is there with tuberculosis, which can involve the genitourinary tract. Any doubts or clarifications at this time? Have any questions? Matted lymph node is a palpatory finding. It's not a radiological finding. Any other questions?
Just a second. Two questions, sir. One is, what is the reason for evening rise of temperature in tubercular fever?
Okay. So remember, tuberculosis produces a low-grade continuous fever. And as you know, the normal circadian rhythm itself, in the evening, the temperature would rise by 0.5 degrees centigrade or 1.2 degree Fahrenheit. So the baseline fever itself, supposedly you have a 37.2 is normal in the morning, 37.7 is normal in the evening. This tuberculosis produces a low-grade fever. So the temperature might have elevated to around 37.5. But what happens to this? In the evening, there is a 0.5 adding to it. So the 37.5 becomes 40. So that's where the patient will feel the temperature. So it's a low-grade. Any low-grade fevers generally have evening rise, basically because of the addition of temperature. 0.5 is added to it. That's why it gets like that. That's the reason for evening rise.
One more question was, what is the difference between disseminated tuberculosis versus miliary tuberculosis?
Yeah, disseminated tuberculosis. See, miliary is where you have the miliary mottling sort of things. You should have those discrete miliary forms. Okay. Dissemination can happen just from the lung to the brain. TB meningitis can happen, or the lung to the pleura, or the lung to the pericardium. You can have dissemination. But then when you have a miliary pattern where it's studded with miliary, you find that the liver is studded, or the spleen is studded, or the peritoneum is studded. Such a disseminated tuberculosis is called as disseminated miliary. Miliary is a specific pattern. Dissemination is, it can get disseminated. Yes.
One question was, what are the various tests by which we can diagnose TB bacilli in the blood?
TB bacilli, there are no tests that are there. Only the IgA and IgM is available. The sensitivity is less than 40%. So there's nothing in the blood which is good test to detect tuberculosis. We have to have the samples from the respective sites, either the sputum or the fluids. Even the CB-nat in the blood is not to be done. It's very, very poor. The most specific test that we have now is the CB-nat, which has the sensitivity and specificity very high, but in the blood, it's a very, very low specificity in the blood for that.
One more question now they've asked is it mandated to do investigation for TB in all HIV patients, or is it only for symptomatic?
Yes, yes. You have to check. Any patient HIV positive, you will have to check for tuberculosis. You'll have to do a simple X-ray. You will have to do, if the X-ray has shadows, you will have to do the sputum testing also, because if tuberculosis is there, we will ideally start the treatment early for tuberculosis and then start the ART. And vice versa also, all patients with tuberculosis have to be tested for HIV. That is also needed.
One question regarding lab, sir. If we have to test for CSF, which would be the ideal test to look for tuberculosis? Is it better for ADA versus CB-nat, sir?
Ideally would be CB-nat. See, again, remember, ADA is based on the cells. ADA comes from the lymphocytes that you're seeing there. So the number of lymphocytes is going to give you the, especially the isoenzyme of ADA. If you can do the ADA2, that's more specific for tuberculosis, but it's not available everywhere. CB-nat is definitely, ADA is suggestive of tuberculosis. But CB-nat, if it is there, it is definite of tuberculosis. And it says that there is an active tuberculosis with CB-nat. CB-nat is any day more specific and more suggestive of tuberculosis than AD. AD can be elevated in lymphoma also.
And one question was with regard to various fluids that we usually analyze, ascitic, pleural versus CSF.
Yes.
Which of these would have best yield for ADA levels to test for, sir, in tuberculosis? Is there any variability like that?
I could not hear your question. I think there was some.
Sorry, sir. So with regard to the various body fluids, with respect to either ascitic,
Yes.
pleural, or CSF,
Yeah.
which of these would have a better yield for an ADA if we have to rule out a tuberculosis or suspecting?
ADA has been, yeah, that's what. See, it depends upon what is the disease. If it's pleural effusion, we'll obviously do pleural only. ADA has been described for pleural fluid only. ADA, tuberculous pleural effusion, is by far the commonest serositis that we do get. And ADA has been studied definitely, and the levels, what we say, the cutoffs, we are saying 40 and above, and less than 12 is less impossible, not possible. It's all for pleural fluid. It's not for, we are extrapolating the same thing to the ascitic as well as the ascitic or the meningeal. The ADA has been studied basically for pleural fluid. All the studies are basically based on that. We do not have a head-to-head comparison with other fluids.
The cutoff same for all of the fluids, sir?
That's what the cutoff has been defined for pleural fluid. We are extrapolating the same cutoff for all the fluids. The other cutoffs of ascitic as well as the CSF is not available. There are no studies which say that. The cutoffs are not there actually. The cutoff is only, studies are there for pleural fluid cutoffs. So we use the same cutoffs for all the other fluids.
Yes, sir. I think those were the questions that are there.
Okay, we'll proceed quickly with the treatment. So that's important. So I've already described you the two major categories that we have, either bacteriological confirm, either you have a sputum smear, or you have a CB net positive, and the clinically diagnosed. Those are the two varieties. It could be pulmonary or extra-pulmonary. Please remember, pleura is extra-pulmonary. Pulmonary is only lung. Either it could be the cavity, either it could be a miliary, it is the lung only, whereas extra-pulmonary is anything other than the lung. The earlier categories which were there, new, previously treated, etc. Now you have only two categories that are there presently in the dots. You have the new and the previously treated. Only two categories that we have. There is no treatment failure, etc. We had other categories which were there earlier. I won't go into the definitions. Very important is to see the HIV status. The HIV positive TB patients, HIV negative TB patient, and HIV status unknown TB patient. These are the three categories. Now it's only the positive or negative because HIV test is mandatorily done. We have large number of drugs that are available. The good old drugs which are still effective. However, the resistance is coming up and we have a few new drugs that are available, but still the old drugs are the ones which we have useful even now. So the first line drugs, the rifampicin, isoniazid, pyrazinamide, ethametol, and streptomycin. Drugs in tuberculosis is mandatory for undergraduates. You have to know it thoroughly because this is going to be asked in theory. It's going to be asked in practicals. Even in your Viva, one of the stations is drugs. So you will be asked about anti-tuberculosis. You have to know everything about anti-tuberculosis drugs, the mechanisms, the what is the dosage, what is the side effects, and what's the duration of therapy. That is important. The second line are the toxicity levels are higher. The efficacy is little lower compared to the first line. The major categories that you have, the ethionamide, the prothionamide, the cycloserine, the para-aminosalicylic acid, the thiacetazone, the fluoroquinolones, and injectable aminoglycosides. Bedaquiline, which is a new drug, has come into the category of the reserve drug now, and it is used for MDR therapy. As of now, it is available. That's the only second line drug. That's the only novel, newer drug that is available. All the other second line drugs are available for MDR therapy. So the basic classification is based on the most potent, as we have the first ones, that is the first line oral drugs. The first line injectable drugs are the aminoglycosides. The third is the injectable fluoroquinolones. Then you have the second line oral drugs, and then the newer drugs where you have an unclear efficacy, where you have the thiacetazone, clarithromycin, clofazimine, linezolid, amoxicillinic acid, and imipenem cilastatin. These are indicated in drug-resistant tuberculosis. When you do not have anything to give, we do give this. Based on the tuberculosis foci, the drug classification is based on where are they acting. Streptomycin basically acts extracellularly. Rifampicin acts in the rapidly metabolizing mycobacteria. That's why rifampicin is a good sterilizing agent. The drug which acts in the acidic pH and acts in multiplying bacilli, less active in multiplying bacilli, and in close lesion is isoniazid. The penetration is little poor with isoniazid. On dormant bacilli, the drug that is effective is the pyrazinamide. So pyrazinamide is effective to prevent the relapse. So all these drugs have their own mechanisms that will be there. So if you see the extracellular rapidly multiplying organisms, the isoniazid, rifampicin, and streptomycin is predominantly effective. The extracellular intermittently multiplying organism, rifampicin, is best there. Intracellular dormant bacilli, pyrazinamide is best here. So dormant bacilli, the slow multiplying bacilli, pyrazinamide is better. That's why when you use a combination of that, we could target the majority of the bacilli. If the dormant bacilli is there, which is not at all multiplying, then we do not have any drugs to act for that. So isoniazid, the mainstay therapy that you have, and it is inhibition of the mycolic acid. I wouldn't go into the details of that. Important is it is metabolized by acetylation, and based on the acetylation, you have two groups of people. One is called as the rapid acetylators and the slow acetylators. The rapid acetylators are generally the ones who develop hepatitis. The slow acetylators are the ones we develop neuropathy, that is. So the side effects of INH. So as you say, I stands for idiosyncratic reaction. That's the first side effect that is there. N stands for neuropathy and H stands for hepatitis. So INH stands for idiosyncratic reaction, neuropathy, and hepatitis. The neuropathy can be prevented by giving pyridoxine. So pyridoxine can be given 100 milligrams per day, and you can, importantly, you have to give it, especially in patients who are alcoholics, or they are patients who are diabetic, or HIV patients. You have to supplement pyridoxine definitely in these patients. Rifampicin, Again, it inhibits the RNA synthesis. It has a large amount of interaction with drugs because it is a enzyme inducer. So large amount of reactions that are occurring, interactions with drug that we have to remember. The side effects of rifampicin, again RIF standing for rifampicin, produces the red color urine. It produces idiosyncratic reaction and flu-like syndrome. By far the commonest, they have fever, rash and headache, very common with that. And the severe form of it is the hepatitis it can produce. So rifampicin produces a large number of skin reactions that can be there. And in the severe form, it can produce the flu-like reaction also. Coming on to the next drug that we have is the newer congeners of rifampicin, the rifabutin, which is available now, especially for rifampicin resistance. We give that. Also for non-tubercular mycobacteria and MAC, we can use that. The side effects are same as what is seen in rifampicin. The newer one that we have is the rifapentin, which has a longer duration of action, can be given once or twice a week, 600 milligrams once or twice a week. That is rifapentin. This is not used in the regimens as of now. Other uses of rifampicin, again a very common question they ask you. So rifampicin is a good antibiotic. It has anti-staphylococcal effect. So it can be used for MRSA, diphtheroids. It can be used for leprosy. It can be used for brucellosis. It can be used for Legionella infection and also prophylaxis for meningococcal and H influenza meningitis. So rifampicin has wide variety of uses. Pyrazinamide, that's Seidel drug and it is effective against the dormant. The important side effect is hepatotoxicity and hyperuricemia. The most hepatotoxic drugs of the first line therapy is pyrazinamide. And it's important to know that pyrazinamide produces something like a hypersensitivity hepatitis. So if you challenge it again, then the possible chances of death is much higher when you challenge the drug again, especially with pyrazinamide. And gout, very common, hyperuricemia and gout is seen with pyrazinamide. Coming on to ethambutol, again, it is effective. It's a static drug. It's effective against MAC also. The main side effect, what you have to remember, is the retrobulbar neuritis, and they have the loss of red-green vision that would be there. So you should be very carefully telling about this to the patient, and they have to keep a watch on this. So ethambutol. One more thing that you have to remember about ethambutol is it in a patient who has a renal failure, maybe it requires a little dose adjustment. Ethambutol might be needed. So the other first line drugs we have is the aminoglycosides. We'll be discussing it together. So aminoglycosides, very potent drug. They are Seidel and they are there both in the first line and the second line. Important side effects are the nephrotoxicity, ototoxicity, and they can have peripheral neuropathy also. Streptomycin is the good drug, and that's the first line drug. All the rest are in the second line. Fluoroquinolones, again, they are Seidel drug, available both oral and IV. The drug that has been in the regimen is the moxifloxacin, but other quinolones like ufloxacin, ciprofloxacin, levofloxacin, and gatifloxacin can also be used. The problem with quinolones is that quinolones have been rampantly used for many other indications, be it respiratory, sinusitis, etc., and the urinary tract infection. So they have ceased to become very much effective against tuberculosis at present. Especially in India, the fluoroquinolones rampantly used for other conditions. You have these problems that could happen. Ethionamide and prothionamide, this is used for MDR drugs. Problems with this, again, it produces hepatitis, peripheral neuropathy, and can produce goiter. Cycloserine, it's a tuberculostatic drug. It is, again, this is one more drug which can produce neuropsychiatric manifestations. So it can produce tremors, it can produce psychosis, it can produce depression. So you could get side effects of that. So cycloserine, we have to be careful in neurological problems. PAS, possibly one of the oldest drug that is available, para-aminosalicylic acid. It can produce a lot of GI side effects, and it can again produce hypothyroidism. Both ethionamide, prothionamide, and PAS can produce hypothyroidism. Macrolides, azithromycin, clarithromycin, have action. This is predominantly reserved for MAC infection rather than the traditional, but you can use it in drug-resistant tuberculosis also. The newer anti-tubercular drugs, as I've discussed, the beta-lactams, that is the imipenem, amoxicillin, clavulanic acid, linezolid, clofazimine, dapsone, metronidazole. Again, these are roles are not well established. These are only used in when you have a extensively drug-resistant tuberculosis. Bedaquiline, that's the one which is available now. It is a proton pump of ATP synthesis. That is where the action occurs, and this is available now for the treatment of MDR tuberculosis. Delamanid and proteonomid both are available, but we are not using it as of now. Sutazolate, that's basically binding onto the 550S ribosomal unit of the, and that's how it affects. The newer drugs are still there, but these are the ones which are available. Bedaquiline, delamanid, proteonomid, and sutazolate, all are available. What is used now is bedaquiline. And one important thing you have to monitor whenever you do the give the bedaquiline is the cardiotoxicity. So you have to take an ECG and monitor the QT interval. That is what you have to be monitored. So coming on to the treatment regimen. So now we have only two regimens that are there. One is for the new disease, one is the previously treated disease. For the new cases, the treatment regimen is 2 months of HRZE and 4 months of HRE. Please remember this. It is the 3-drug regimen for 4 months. Ethambutol is continuing for the continuation phase also. So 6 months therapy, 2 months of HRZE and 4 months of HRE. H stands for isoniazid, R stands for rifampicin, Z stands for pyrazinamide, and E for ethambutol. Now the previously treated patients, the regimen is 2 HRZES, where streptomycin is given for 2 months, and then 1 month of HRZE and 5 months of HRE. So it's an 8-month therapy that we use for tuberculosis. Now the treatment of other tuberculosis, supposedly you have tuberculous meningitis, the regimen can go as long as 12 to 15 months also, and streptomycin can be added for the first 3 months there. Disseminated tuberculosis also, the treatment can go up to a year. The continuation phase can be prolonged for a year. So please remember what has changed from the earlier. Earlier it was thrice weekly regimen, now it is daily regimen. And the most important thing is ethambutol is going to continue for the intensive phase as well as the continuation phase. So this change has occurred way back in 2018 and 2019 onwards. This is what is followed. So daily regimen, ethambutol continues for the continuation phase in both the categories. And earlier they used to extend the intensive phase. Now the intensive phase ends at the 1 month, but then you can continue the continuation phase also for more based on the duration of based on the disease that we're dealing. Especially TB, meningitis, spinal tuberculosis, we extend it for a year to 15 months. So that's the algorithm that is available now. So cough, sputum smears. If it is negative, CB-NAT. If X-ray is positive, it is clinical diagnosed. If it is sputum or CB-NAT positive, it becomes microbiologically diagnosed. If you have a biopsy, it becomes a microbiology diagnosed point. Treatment of TB in special situation, pregnant woman, streptomycin is contraindicated. Pyrazinamide has to be used with caution. That's the important thing. Women on OCPs, the rifampicin can be, the efficacy of rifampicin can be decreased. So you have to ask the patient to use some other form of alternative contraception when they are on ATT. Chronic liver disease, remember your main drug regimens that we have, that is your rifampicin, isoniazid, as well as pyrazinamide, are all hepatotoxic. They are all hepatotoxic. So the risk is very high, especially when the albumin is low. And if the patient develop hepatitis, they can go into encephalopathy and succumb because of that. So in already decompensated liver disease, you can have two regimens. One is the avoiding the pyrazinamide using only HR. This is the 2 hepatotoxic regimen. Use streptomycin, isoniazid, rifampicin, and ethambutol for 2 months and continue it with 6 months of rifampicin and isoniazid. At present, we add ethambutol also for this. The second regimen is where you use only one hepatotoxic drug and you're using INH. That means you use 2 months of isoniazid, streptomycin, and ethambutol and continue 10 months of isoniazid and ethambutol. Those are the 2 regimens that could be there. And then you have the no hepatotoxic regimen where we are avoiding both isoniazid, rifampicin, and pyrazinamide. And you're only using streptomycin and ethambutol along with a second line drug, either a moxifloxacin, a quinolone is used, and you continue the continuation phase. So streptomycin is used for 2 months, and then the continuation phase. This continuation phase can continue for 15 to 24 months. So this is the 3 regimens that are available for chronic liver disease. In renal failure, I told you we avoid ethambutol. Streptomycin cannot be given at all. Ethambutol is avoided. You can use 2 months of HRZ and 6 months of HR can be given. Very important question they ask you is what's the indication for steroids in tuberculosis? The indication of tuberculosis steroids is adescence. So hypoadrenalism is the main indication. You can use whenever there's a drug hypersensitivity. TB meningitis we use for the first 2 months. Basically, it's to prevent the since the CSF that is there is highly protein rich, so it can cause exudates and the cranial nerves can get trapped in that. So to avoid the fibrosis, we use that. Also, steroids will improve the penetration of the drugs into the meninges. So the first 2 months we use. TB pericarditis, sometimes TB pleural effusion also we use for the first 2 months. TB laryngitis, renal tuberculosis, or when there is a compression, either due to a lymph node or some tuberculous mass which is producing a compression, such is an indication for steroids. But the absolute indication for steroids in tuberculosis is TB adescence. That is what you have to remember. A few words about drug-resistant tuberculosis. So you have the MDR, you have the monodrug resistance, you have the INH resistance, rifampicin resistance, but that's not important. MDR is where you have resistance to both isoniazid and rifampicin. Extensive drug resistance where you have resistance to MDR plus one of the aminoglycosides, which is there, injectable aminoglycosides, or that is capreomycin, kanamycin, or amikacin with the fluoroquinolone. And totally drug resistance is where there is a resistance to all first line and second line therapy. Now, TDR cases are more commonly seen with healthcare professionals, and we do find large amount of mortality in them. So that's the worry of TDR. It's increasing. So basically, we have to suspect if the patient is not improving once you started on treatment. We have to suspect resistance. We have to do a conventional culture or a tactic. Or the present ones, you have the first generation line probe assay, which can detect resistance to isoniazid, and second line probe assays can detect to resistance to fluoroquinolone and other drugs also. So drug sensitivity can be done, and based on the sensitivity pattern, we will have to start the treatment for drug resistant tuberculosis. So again, the intensive phase can go up to 6 to 9 months, and the continuation phase can go up to 18 months. Remember, the drugs have to be at least 4 to 5 drugs which are sensitive. That is what we'll have to use, and preferably an aminoglycoside is used, or a quinolone, which is supposed to be given parenteral, has to be used for the first 6 to 9 months. Extensive drug resistance, again, the intensive phase for is 1 year, and the continuation phase is for 1.5 years. Again, there we do not have much drugs, so we generally use a combination, high dose INH with para-aminosalicylic acid with an aminoglycoside, quinolones, etc. are used. For TDR, as of now, we do not have any drugs available for treatment. For MDR, bedaquiline is being put up now. INH resistance, isolated INH resistance, bedaquiline has been put into the regimen now for treatment of MDR tuberculosis. A few words about tuberculosis chemoprophylaxis. Now, this is to prevent the latent tuberculosis into progressing into active disease. So it could be primary or it could be secondary. Primary is where it's given in uninfected individuals to prevent the disease, especially the breastfed infants of the positive mothers. And secondary is given in people. I'll come to the indications. So the drugs, various regimens. What is followed in India is isoniazid only. They give 300 milligrams of isoniazid for 6 to 12 months. You have the other regimens are there, which are isoniazid plus rifampicin, isoniazid plus rifampicin for 3 months. These two regimens are there. A few studies have been done with this shorter regimens, but the efficacy has not been proven. So as of now, IPT, isoniazid preventive therapy, is what is practiced, especially in HIV patients. So the indications for chemoprophylaxis is close contacts of open cases with a recent MAN2 conversion. Close contacts, especially children less than 5 years with strongly positive MAN2, because these are the ones who are prone to develop TB meningitis. Breastfed neonates with sputum positive mothers, it's indicated. Newly infected patients who are tuberculin skin test negative has become positive, or the patient is suffering from. This is the indication, HIV infection. As of now, the IPT has been used. Patients who have immunocompromised state, or the patients who have diabetes mellitus, etc. So all those things, they can be used. So these are not hard, fast indications, but in children, we use isoniazid preventive therapy. And now for the last 2 years, in HIV patients who do not have tuberculosis in the past, who have a MAN2 positive or IGRA positive, they have been given INH prophylaxis. What is the problem with this is development of INH resistance, the hepatotoxicity. And very importantly, we have to rule out active disease. We have to go ahead and rule out all possible ways to rule out an active disease. Because if for an active disease we use only INH, we are going to cause more resistance. Any doubts at this point? I have 2 more small sections to go. Okay, I think we'll continue. The very important combination that we have is TB and HIV. I think in the section in HIV, I had made some mention about what's the difficulty that we have when you have TB and HIV. We'll discuss that in a little more in detail. So here, HIV increases the susceptibility to tuberculosis by 10-fold. Among the patients who are HIV, the lifetime chance of tuberculosis is 50% compared to around lesser in non-HIV infected people, which is around only 5 to 10%. And again, as I told you, extra-pulmonary tuberculosis is seen in almost 50%. Drug toxicity, the drug intolerance, because there are multiple drugs these patients will be on, that will be difficult. Also, the typical features may not be seen. The X-ray may not show cavities. The sputum may not be positive. So that is also a problem in HIV patients that we see. If you see the various phases that you have in a classical HIV disease, so you have the initial acute phase, then you have the chronic phase, and then this is where the antiretroviral therapy you start, and that is where the risk of tuberculosis is the highest. You can see that tuberculosis comes in CD4 above 250 itself. It's not when the CD4 is very low. The atypical tuberculosis comes when the CD4 is less, but the tuberculosis per se is there. And as the immune activation increases, when the CD4 counts are high, increasing, that is where the risk of tuberculosis is high. That is one thing which you have to always remember. The early HIV and late HIV, in early HIV, when the CD4 counts are good, the patient will have the classical tuberculosis, the smear will be positive, you'll have cavities that you see. But in later HIV, when the sputum, when the CD4 count is low, it resembles like primary tuberculosis. Maybe just have a lymph nodes, and you may have infiltrates which could be there, and sputum may be negative. That is what you have to remember. Coming on to the antiretroviral therapy in tuberculosis, the problem is we have a large number of drug interactions that we have. So all patients with TB and HIV should be evaluated, determine if antiretroviral therapy is indicated. So as of now, the guideline says any patient with HIV with tuberculosis will receive ART definitely. All patients with HIV will receive ART, but ones who have tuberculosis will receive ART as soon as possible. So there are a large number of drugs both in the ATT as well in the ART, and we have a lot of reactions that could be there. So you should have a careful watch and expectancy. The baseline investigations have to be done. The liver function test, the blood counts, the renal function test, the albumin has to be checked baseline itself before we initiate. Initiation of tuberculosis treatment should not be delayed. That's the first thing that we start. And antiretroviral therapy can be delayed up to 8 weeks. Okay? Up to 8 weeks you can delay, and then you can start. So indication of ART in TB HIV patients depends upon what is the status, CD4 count, and is there any adherent and toxicity issues, etc. But please remember, all patients, as of now, the guideline says all patients who have HIV and tuberculosis will have to be started with ART as soon as 8 weeks. Before that, you can start. So if TB develops 6 months after starting ART, so you can straight start the first line therapy for ART, and there is no need to change the ART regimen. But if the patient develops TB after 6 months, that means there is a chance of a clinical and immunological failure. So we will have to look into the ART, and we may have to change the second line. And as of now, you do have dolutegravir based regimens that are available, and that can be switched on. The key point is always start TB treatment immediately. Do not delay the TB treatment. So if the CD4 count is less than 200, 2 to 8 weeks after the startment of TB treatment, you can start on ART. Supposedly the ART is not started and it's a new patient which is there. If the CD4 count is more than 200 and less than 350, you can wait safely up to 8 weeks. And if the CD4 count is more than 350, you can actually wait. But as of now, the guideline is same for more than 350 also. 8 weeks after starting ATT, you would start them on antiretroviral therapy. But please remember, the CD4 count is lower. We should try to start ART as soon as possible. That is what you have to remember. When to start antiretrovirals, I've already discussed this. So I won't go into this. The regimens that are there, efavirenz plus 2 nucleotide regimens, that is the 2 NNRTI regimens. So this is only to be avoided in the first trimester of pregnancy. That is one where we have to avoid it. Otherwise, we can give it in adults. It is safe. With nevirapine and efavirenz, remember the nevirapine decreases the effective of rifampicin to almost 58%. So the chance of treatment failure and drug resistance is very high. In comparative to nevirapine, efavirenz decreases to around 22%. So there is an interaction with both the NNRTIs, but efavirenz is better than nevirapine. That is what you have to understand. ART and rifampicin based TB regimens, when you choose the NRTIs, so always you have the backbone that is there of NRTIs, zidovudin, lamivudin, stamivudin, lamivudin, whenever there is an anemia. What is the problems that could be happening? They are safe. When we come on to the protease inhibitors, if you see the protease inhibitors and the effect of rifampicin, the saquinavir decreases the rifampicin effect by 85%, ritonavir by 35%, indinavir by 89%, nelfinavir by 82%, amprinavir by 81%, and lopinavir-ritonavir combination decreases by 75%. So the only protease inhibitor which is relatively okay is ritonavir, but we do not use ritonavir alone. So we use a combination of lopinavir-ritonavir combination. So again, protease inhibitors are of will cause the failure of rifampicin. So rifampicin will become ineffective in these cases. So that is the main problems that we have when we have rifampicin based regimen. If you have a rifabutin or rifapentin based regimen, these side effects will not be problematic. That's there. So either the options that are there is a triple NRTA combination, that is a abacavir tenofovir with 2 NRTA combination that's there, or the nevirapine 2 NRTA combination that can be used, or the present regimen that we have is the dolutegravir based regimen, which can also be used safely whenever we have ART. So this is the regimen which has come up now, and for the past 2 months you would have noticed that every new patient has been started with the dolutegravir based regimen. So a lot of studies are not there based on the long-term efficacies in patients with tuberculosis. But what has been studied by a large trial which was done in the African continent, it showed that among patients who were on dolutegravir versus non-dolutegravir regimen, 90.9% and 80 to 85% achieved TB treatment outcomes. And thus the dolutegravir based regimen showed slightly better. Where you had the odd ratio of around 1.56. That means it is the ratio, the ranging between 1.06 to 2.31. So you thought the dolutegravir regimen was much better in the outcomes, that what they said. And also earlier there was a lot of possible drug-drug interaction between dolutegravir and rifampicin, resulting in the decreased concentration of dolutegravir. So this was the problem that we thought. That is why WHO recommended a twice daily schedule whenever we are using rifampicin based regimen. Twice daily schedules versus a single instead of a single daily dose of dolutegravir in TB HIV patient who are on rifampicin based anti-TB therapy. But the study which I told you, that is this study that has been there, which was done, published in 2019, showed both the patients, there was a limb where we had a double dose of dolutegravir. Also there was a limb where there was a single daily dolutegravir regimen. The efficacy was good in both of the regimens. However, WHO still recommends that a patient who has rifampicin based anti-TB therapy, dolutegravir dose has to be doubled. So the HIV-TB co-treatment in drug-sensitive patients. So supposedly efavirenz is there, rifampicin, you do not have to do any dose adjustment. Just watch for the CNS toxicity. If your lopinavir-ritonavir has the worst problem on rifampicin, so rifabutin can be replaced. That is what would be the thing. Very important, monitor for the uveitis. When you're using raltegravir or dolutegravir, as far as raltegravir was there, they said that the regimen has to be changed to twice daily. Raltegravir is a higher 400 to 800 milligram. Whereas dolutegravir, you have the trials which have said on 50 milligrams of dolutegravir have to be given twice daily. So that is what is there. And nevirapine is best avoided. So nevirapine is best avoided. So if possible, efavirenz-based regimens can be continued. Lopinavir, ritonavir, you have to change it to rifabutin. And with raltegravir or dolutegravir, you will have to make the dose twice daily. That is what you have to remember about when we treat a patient with HIV with tuberculosis. The drug toxicity will increase. Rash is common with pyrazinamide, rifampicin, INH. It is common with the tenofovir. It's common with NNRTIs. Hepatotoxicity, all first-line drugs, PIs and nevirapines. Nausea, again the first-line drugs of ART, ritonavir, atazanavir also. Cytopenias can be common with rifampicin. Central nerve CNS side effect, efavirenz can cause that and INH can cause. So you have to generally look onto it and keep a careful watch on the side effects. And again, remember, it is not only the antiretroviral drugs these patients are on. Patients with HIV are on other drugs also, which can also have a lot of side effect profile. Coming on to the new drugs effects which you have, if you see the bedaquiline, the cardiac toxicity has to be monitored, and whenever you are on efavirenz regimen, etc., the bedaquiline dose has to be decreased to 50%. Lopinavir ritonavir combination, bedaquiline has to be increased twice. Delaminid, we do not have much studies with the HIV. Proteanomid, there has been a study with HIV where the dose reduction is being advised to 35 to 17%. That is there. Sotazolid, again, we do not have studies to do it. Other issues when you treat TB and HIV, again, is the other drugs, especially the cotrimoxazole. Most of the patients we have discussed in the HIV sections when we discussed HIV patients will be on cotrimoxazole, and cotrimoxazole itself can have a large amount of side effects which can be a mimic, which can produce rash, it can produce hepatitis, it can produce cytopenias also. So cotrimoxazole is also very important. So when you have ATT, when you have cotrimoxazole and we have ART, so the combinations can produce quite a lot of complications that could be there. So skin rash can be seen in all of them. Nausea, vomiting side effects can be seen with all of these drugs. So we should be aware of these overlapping side effects that are there within these combinations. Again, hepatitis can be seen with all these drugs which I've already discussed. Leukopenia and anemia can also be seen with zidovudine, rifampicin, as well as cotrimoxazole. One more thing, if you very classically see a patient with TB and HIV, when we start treatment, you find that there is a shadow here, which is resolved after 2 months, but 6 weeks later, you find that the chest X-ray is worsening. So what is happening? Why is this worsening that is happening? And that is what we call it as the immune reconstitution inflammatory syndrome, where the immunity improves, the CD4 count improves, the florid manifestation of the disease can come, which could be paradoxical or it could be unmasking. We have discussed this earlier in the HIV section. So where the patients have a disseminated tuberculosis or the starting of ATT and ART shorter duration, a low baseline CD4 count, a high baseline viral load, they are the ones who have to be are more prone to develop this iris. So generally, whenever we have TB with ART starting, we generally wait up to 6 to 8 weeks. But the problem is when the CD4 count is low, we are expected to start the ART as soon as possible. Coming on to the last section, which is relevant as of now, is the TB and COVID-19. With the COVID-19 pandemic that is affecting us for the past more than 1.5 years, and tuberculosis being rising, what is the relevance of that? So it's said that there was 1.49 million deaths worldwide due to tuberculosis in 2018, but the deaths have just increased to 1.85 million in 2020. Basically, because the TB case detection fell down by 50%. So we have lost a large amount of old tuberculosis patients, and there's been a major disruption in TB case detection, and more than 400,000 deaths or lives have been lost. And the detection rate in the last 1 year with the lockdowns and etc. has fallen down to 50%. And that's what we are going to face in this coming years with that. So the wider impact of the COVID pandemic, it's not only to the COVID-related tuberculosis. We say that there is a 1.4 million deaths will occur by 2025. Malarial deaths also are going to increase. The HIV-related mortality, MCH, etc. All are going to be affected because of this COVID pandemic. And with the shunting of the budgets for other like the RCH or the vaccination budgets, which has been shunted towards the COVID vaccine, the other diseases also are going to eventually get affected. So this is what has happened in India in 2020, before and after lockdown. We found that the number of cases were this, and all of a sudden, when the lockdown was announced, you found that the new cases we did find gross dip. People taking the treatment also grossly decreased, and that is what is the cause that has caused death as well as possibly resistant patterns also. The adjusted risk that has been there for COVID-19 mortality among patients with who had current tuberculosis in COVID was 2.7. So COVID tuberculosis was an independent risk factor there. With previous tuberculosis, the rate was around 1.5, and the adjusted HR for HIV with COVID was almost 2.14. So all of these had a direct bearing with the COVID-19 mortality. So patients who had past tuberculosis, previous tuberculosis, current tuberculosis, and HIV had an increased mortality during COVID pandemic. That's what has been studied. And this is what we are expecting to increase with the COVID-19, the resources getting shifted. We would find that there would be a large number of increase in the other diseases over the next few years. We are thinking that since everything has got shunted to the COVID-19, we find that the large number of other infectious diseases would probably increase. Only time will say how it is going to change. I think 2019, 2020, the WHO came up with this slogan on the World Tuberculosis Day. World Tuberculosis Day is just around the corner. March 24th is World Tuberculosis Day. And that was the main thing that they came up with, end tuberculosis. This was brought, I think, in 2019. 2020, the same goal was been achieved. But due to this COVID, it was unprecedented. So quite a lot of program related things did not happen. I think the same thing continues for this year. So it has to be a active case finding, detection of resistance, and appropriate treatment, and possibly isolation of the cases, which would help us to decrease this mortality, morbidity, and the spread of tuberculosis. Otherwise, tuberculosis is going to remain as long as patients' immunity would go down due to any reasons like HIV or others. So otherwise, it will be difficult to end the menace of tuberculosis. I think with that, I end my session. I'm open for any questions.
I request all the members sitting there and watching there to give a big round of applause to sir from wherever you are and however you are conditioned. Please, from our side, at least this much of gratitude from our side. One of the most amazing and brilliant sessions. Tuberculosis cannot be made easier than this or made explained better than this. Sir, now we really understand, sir, why students throng to attend your sessions. So, sir, one of your sessions got deleted by mistake from our channel, sir. We received minimum 100 messages for that to upload that, and yeah, we are trying hard to edit that and upload that. There was some the gap in the middle, so we are not able to make it up. So that shows, sir, how much students are really impacted by your classes and how much they are getting motivated and all. I don't know, sir, how to thank and all. You are our own, so I don't specially thank. But yeah, sir, please be with us to guide and teach us. And you are, sir, you are the best, sir. No doubt about that. You are the best, and we want to learn from the best. That's it. And thank you so much, sir. Wonderful session. Any doubts from any of the members, please?
Streptomycin is not used anymore. Streptomycin is, yeah, I think last year somewhere before 1 year prior, streptomycin was withdrawn, but streptomycin is still used in the when you have a resistance pattern, we would still use streptomycin. In the middle, streptomycin was removed, definitely. That was there. The latest TB guidelines, there is only one category. Yeah, it's the newly diagnosed tuberculosis. That's the category that we have. And the old tuberculosis will be treated as MD. I mean, the resistance, drug resistance pattern only. Based on that, we'll have to go ahead. What guideline I showed you was the 2018 and 19 guideline. As of now, you have only the newly diagnosed tuberculosis category. Earlier, we had the MDR, XDR separate categories that have gone. Previously treated is considered, we'll have to do the resistance pattern, and then based on that, we'll have to treat it. Patients with tuberculosis have altered sensorium. Yes, TB meningitis is common, but more importantly, tuberculous adescence is also common. Hyponatremia that is very common in tuberculosis. We will have to rule out adescence in patients, and if they are started on treatment with the steroids, they do improve a lot. So we have to rule out that tuberculosis adescence is common. And many patients we find when starting steroid, that's a risk where you can have exacerbation of the tuberculosis and you can have dissemination. But if there is adescence, unless you start the steroids, the patient would not improve. So we'll have to take a call on that. Alkaline phosphatase raised generally indicates a diffuse liver involvement. Okay, it's something like a granulomatous, where on ultrasound you may not find anything, but if you do a biopsy, you would find that there is granuloma. It's like a diffuse involvement of the liver. It could be a part of a disseminated tuberculosis. So that is what you have to remember. So that's not a contraindication for ATT. ATT can still be continued. As far as the patient is tolerating, you can continue. Alkaline phosphatase elevation could be due to intestinal tuberculosis also, but it could be diffuse liver involvement. Previously treated are not assumed as drug resistant unless you get a drug resistant pattern. Okay? Unless we get a drug resistant pattern. And again, streptomycin, I know the latest guidelines do not mention, but specifically when you have a TB meningitis or a TB spine, streptomycin is still the drug of choice. We do use streptomycin in the first 2 months. Disseminated tuberculosis, TB meningitis, as well as TB spine, streptomycin is used for 2 months. That's where we use streptomycin. We do not assume drug resistance unless, see, now the line probe assays and your CBNAT is available. Unless we do that, we can't label anybody as drug resistant. Earlier, we had to wait for the cultures. Now we can do this CBNAT and line probe assays and can get the drug resistant pattern within 2 to 3 weeks. So we will label them as resistant only if the pattern is available. We can suspect drug resistant, but we have to label them as resistant only once the pattern is available. Any other questions from the other chat? I think here I have answered it. YouTube, anything?
One question, sir. Treatment duration for MDR will be 18 months or more than 2 years?
It depends. It depends on, see, again, that's a very, so-called a dynamic thing. What is recommended is 18 months, but then if the patient does not improve or develops, not significantly improves, like it's the same like TB spine and all, TB spine, they continue the regimen for, ideally extra-pulmonary is 8 months only, but then they continue it for 12 to 15 months. It's all the clinical, based on the clinician's decision possible. What is recommended is 18 months, but can be extended for 2 years also. MDR, XDR treatment is 24 months also. It is the individualized approach that is there. And again, you have to remember, if the sputum is positive, then you can monitor it and you can see the sputum getting negative. But if you do not have anything to be monitored, supposedly the sputum is negative, but then other things are positive, maybe you have a pleural effusion or something like that. We don't have anything to monitor later. So that's a problem there. If sputum is positive, it becomes negative, then there is something, the treatment is occurring. But otherwise, if you do not have sputum for negativity, it becomes difficult to say whether the patient is improved actually or not. It's all clinical based. The regimens can be prolonged. The flexibility is allowed based on the guidelines. It is allowed.
One question, sir. If there is a hepatitis,
yes.
After starting ETT, how often we should first look for hepatitis, and if there is hepatitis, how to reintroduce and how to change the regimen?
So again, basically, what is not practiced is the baseline LFT before starting ATT. Baseline LFT is ideally to be done. Okay, not only the enzymes. Please remember albumin. A low albumin is a marker that this patient can go into liver damage very soon. So drug-induced liver injury is marked prior itself, not only after the drug has been introduced. And ideally, within the first 3 days, we should monitor the enzymes. Clinically, we have to see if the patient gets hepatitis severe form, they will have symptoms, but quite a few of them may not have any symptoms. On day 3, you see it. And afterwards, you can do it every 3 days if the patient does not have any reaction. And afterwards, you can monitor once in 2 weeks. Supposedly, the LFT is deranged and it is more than 4 times of the baseline. Then you'll have to stop all the anti-hepatotoxic drugs and repeat the LFT after 3 days and see whether it is improving or not. Once it starts improving, you can reintroduce the drugs which you have stopped. So you're stopping INH, rifampicin and pyrazinamide. So you're going to only continue ethambutol. That's one more indication where you can either start streptomycin or moxifloxacin, where you're stopping the anti-tubercular drug and the patient is Putam positive. In such condition, only ethambutol is there. You can't give the other 3 drugs. So you can add on either moxifloxacin or streptomycin. And then once the LFT is becoming normal, less than 2 times of what's elevated, you can restart introducing. 2 schools are there which to introduce, whether you want to introduce rifampicin or INH. These are the 2 drugs we can introduce. Always when you introduce with 1/3 of the dose. Supposedly INH, the full dose is 300. We introduce it with 50 milligrams and then increase it to 100. And then we can, if the patient is tolerating 100, we can straight go to 300. And once the patient tolerates INH, you can restart rifampicin. But the new guideline says rifampicin to be introduced first. Again, rifampicin, the total dose is 600 milligrams we are giving. So you introduce 150, wait for 2 to 3 days, repeat the LFT, see if it is tolerating. You can increase to 300 and then increase to 600. And once the patient tolerates that, we introduce both of these drugs and the patient tolerates. We do not reintroduce pyrazinamide. Please remember, if these 2 drugs are safe, then the drug hepatitis is due to pyrazinamide. So we don't introduce pyrazinamide. So that's how you reintroduce the therapy. Again, remember the dosages of INH, rifampicin, ethambutol, pyrazinamide, and streptomycin. It goes by kg per kg body weight. So the mnemonic that you can remember is IREPS. I for INH, R for rifampicin, E for ethambutol, P for pyrazinamide, and S for streptomycin. The dose is 5, 10, 15, 20, 25. 5 milligram per kg, that is INH. 10 milligram per kg is rifampicin. 15 milligrams per kg is ethambutol, and pyrazinamide is 20, and streptomycin is 25 milligram per kg. That's the easy way to remember the dosages. And weight-based regimens have to be, you have to calculate the weight of the patient. Sometimes there could be obese patients and you might be underdosing, and there might be emaciated patient where you might be overdosing, and that can result in side effects. Yes.
So I think this mnemonic is very useful to remember as well.
Yeah.
And one question has come up. So if a patient is started on ATT and 3 months later he has come with pleural effusion, how do we proceed? Whether should we suspect an extrapulmonary disease? How do we proceed with that?
Again, if it's a drug-sensitive tuberculosis and you started the treatment, so it's pretty unlikely that the disease progresses. Okay, but then if it could be a drug-resistant tuberculosis, the patient can develop pleural effusion. Usually, hypersensitivity reaction develops within the first few, maybe a month or something. But if it is tuberculosis effusion develops later and it was not there earlier, definitely if it is tuberculosis, it's a drug-resistant tuberculosis, or we'll have to rule out other causes. Very common things, especially young patients, young females, SLE is very common there, and we generally see the pleural effusion and start on ATT, but then it's actually lupus that is there. As well as in a little older patients, lymphoma is common coexistence. So we will have to rule out the other diseases. And if sensitive tuberculosis and the new symptom appears, rule out HIV because the patient can go into iris, and also rule out resistance. Resistance has to be, and always look for the second cause. Tuberculosis, though common, it's not the only thing that can be there in a patient. We have to rule out the other causes. Any other questions?
This question is not very clear, but they're saying if a patient has a previous tuberculosis, CBNAT will still be positive for a while, and in that sense, how to diagnose active TB?
The first part I could not hear.
If a patient has a previous history of tuberculosis,
okay,
And they
CBNAT
say
can be
CBNAT may be still positive for a while. So in that case, how to diagnose an active TB in that case?
Its investigation is to be done only once clinical suspicion is there. If the patient has symptoms of active tuberculosis, please remember fever, weight loss, and general malaise and all those things. If there is symptomatic, even if CBNAT is negative, tuberculosis is there. So if the patient is symptomatic, then possibly you'll have to suspect. Otherwise, CBNAT is again a gene-based therapy, a gene-based nucleic acid which is amplified. So I know it can be positive for a longer, I mean, can remain positive for some time, but it cannot remain positive for a full dose of treatment and even after that. Supposedly somebody has received treatment, that means they're finished at least 6 months, and then you're saying this patient has received and come back again. Very unlikely that the CBNAT will remain positive for such a long time. In the initial phases, maybe it will remain positive, but not for more than 6 months. And always, it's a clinical thing that you have to think. If the patient is not responding, or the patient's fever persists, or the weight loss persists, that's where you can think of activity rather than CBNAT alone. Any other questions?
I think yes, sir. That's the end of all the questions on YouTube.
Kind of.
Yes, sir. I think it was. I think it cannot be simplified beyond this. I think all the guidelines, everything together, and at a single point we get. We are really thankful and grateful to you, sir. We seek your guidance all in the further sessions as well. Thank you, sir.